routine clinical practice. So as I said, out of the three, the second one, the posterior segment OCT, is the most common, involving the posterior pole, the disc, and the nerve fiber layer. So why is there a unique role of imaging in glaucoma? That is because of a concept called progression in green. Now it is very well established that the changes in the nerve fiber layer or the imaging predate the onset of visual field defects, and definitely there is a large change or loss of the nerve fiber layer before an actual visual field defect appears. So as you see on the right hand side, the overlap of the visual field loss starts very late in the in this particular descent curve of the loss of nerve fiber layer, and because of which knowing the change in this particular area becomes very important, because it's morally and ethically important that we should not wait for such a big loss to occur before we start the treatment in cases now that the imaging technology has matured enough. So a few snippets of the recent technology. Most of the technology now which we use is spectral domain OCTs. For example, the Spectralis, Cirrus 5000, OptoView, etc., and the swept source, that is the Triton. Majority are spectral domain, and scanning speeds are between 20,000 to 1 lakh scans per second, which is extremely fast. This reduces the scanning speed to average of 5 to 15 seconds per type of scan per eye. Now, this is extremely fast, and it takes care of most blink artifacts that were the main bugbear of technologies like the time domain OCT. And most give analysis of disk parameters and RNFL, whereas some OCT machines do not give the macular or the ganglion cell complex depending upon what make and what generation of OCT they are. So that's why we cannot use all OCTs for practicing glaucoma. And basis the cost and hence the specification, there are vast capability differences in machines, especially tracking hardwares and some specific softwares. But glaucoma, as we all know, needs the highest end machines, because to define progression is very, very important, and accuracy is the main cornerstone of treatment. So these kind of data and studies have always told us that all machines are not the same. The test-retest variability and the axial and the lateral resolution of machines are very different. The inter-operator reproducibility is also very, very important factor, and you can see that it varies a lot between different machines and different parameters in the same machine. So basis that, we basically come to a rule of thumb how we use OCT in modern day clinical practice. So as a technique, it is reproducible and reliable for all its measurements, but all machines don't have the same test-retest variability in its measurement. So that is one thing that we should remember. That's why using any machine for glaucoma is not a good thing to do. Just going for the technical specifications, this particular chart tells you how these machines are slightly different. Although you can see across the board the scanning speeds are almost the same, but the axial and the lateral resolutions are slightly different. Again, you have the scanning methodology is different, where you have a couple of machines giving you disc tubes, whereas Spectral is giving you axial and radial scans, which is very, very important. It's completely different technology as compared to the other three. And some of the technologies give you ANFAS images for localization purposes, which is not there in the swept source OCT. So there are various different technical things which ultimately have a big bearing on what we get as the end result and how we use that in clinical practice. Most important thing here is the tracking indicator in the progression printout. Why I say in progression printout is because otherwise every time you have to, if there is a progression, you have to go to the console and check and recheck, and it's very tedious job, because every time you cannot have the machine at your side to go and check. So having indicators on the progression printout is very, very important for us to judge progression without going to the main machine. As far as the other factors are concerned, you have a few machines which have the SLO images that are inbuilt on the printout, whereas on the others you have the IR images, and the ganglion cell analysis varies as per the machine. It's different in different machines. Some can segment the ganglion cell layer, some can segment the GC with the IPL, some segment GC IPL with the RNFL. So each machine you have to know which machine you are using. According to that, you will get the measurement. So they are not interchangeable because each machine will measure a different parameter. So that is something that you should know. Now, knowing your machine and its limitations is very important. Now, this is something which is asked frequently to me in many of the fora, and that something like, why if I can buy 500 Cirrus at some 20 odd lakh rupees, why should I spend additional 10-15 lakhs for Cirrus 5000? So the answer here is, if you can see, you may have similar speeds and similar technology, but you do not have a live tracking in the Cirrus 500 as compared to the Cirrus 5000. Basis absence of the SLO, and obviously you do not have a test retest alignment with the vessel landmarks in a Cirrus 500 as far as the Cirrus 5000 is concerned. This makes it like apples and oranges, and because of which your progression analysis will be completely different in a 500 vis-a-vis a 5000 in terms of accuracy. So that is the long and short of why and how you should choose higher end machines, and what is the rationale behind using tracking mechanisms for longitudinal progression of glaucoma. So this is the two most important things in this slide. So, which OCT machine to buy is a question that is asked to me in many of the fora, and there were technically correct answer. I'm not saying financially correct, because financially it can be very troublesome, the technically correct answer. It should be a minimally a spectral domain OCT. It should give information about the disc, NFL, and the ganglion cell complex, or whatever. You can have a GCC, GCL, GCIPL, whatever, but you should give a macular analysis. It has to have tracking systems, and it has to have an easy user interface and software analytics. Now, these are the basic things for a glaucoma. May not be required for the retina in that much proportion, but for glaucoma, definitely it is required. In addition, if you have clinical trials and publications to support the use of a particular machine, it's very good. And if you can do post acquisition edits on the image, then it is extremely useful. Now that comes more and more into the technical part of the imaging, which is actually the most important thing, because analysis is as good as the acquired image. So that is something we can talk maybe in detail in some other thing, but you should grossly understand that to buy an OCT machine, all these points have to be covered. Now, as far as the practical application is, once everything is done, considering that you have obtained a good image with all your criteria satisfied, you get n number of types of printouts in each machine. So what kind of printouts you should use also is very important, because when you see the patient along with his printouts in the OPD, then you should have a rough picture of how the acquisition has been, how accurately the image has been taken, how clinically correlating that image is. So all these information you should have at a glance. So the amount of printouts that should be in front of you should reflect all the data that you require to make a decision about a patient of glaucoma. So we'll just show you examples. So here the bare minimum printouts in clinical practice, you understand this simple concept. This is the rationale which printouts you should use. You should have everything that tells you about the entire neuron, that is the ganglion cell, the RNFL, and the disc. So this is the ganglion cell body, which is the GCL. This is the RNFL, and this is the disc. So you should have all the three parameters seen on the map at one time. You should have a scan quality and segmentation related information on the map. You should have inter-eye asymmetry, and you should have alignment details in progression map. So these are basic things that you need to see on a printout to be satisfied to make a decision basis the reports. Otherwise, you have to go on the machine console and check. Now, so this is how these printouts look. Now here, this is the example of a spectralis. This is what I was telling you. So here you should have a disc parameter, you should have a RNFL parameter, and you have a ganglion cell parameter in the same printout. You should have an inter-eye asymmetry printout where you have a segmentation image where you know that all the images have been captured, your quality scores are good, and your tracking alignment feature is here. And also you should have the scans on the right hand side, that is number 4, where you should have all the tracking information, so that over a period of time you can assess whether the image has been tracked properly and whether your progression is giving you a correct answer or is it fudging data. Now, coming to the most common printout here, I wouldn't spend much time because there are many what you call seminars dedicated to interpretation of printouts. But grossly, this is the most common printout that is available or that is seen or described. That is the printout of the serous. Now, important things here, I will just highlight only the most important things what you need to see, because rest of the things are been described. One is that you have to see the quality score. Quality scores as high as possible is important. After, I'm not going about the patient data and all that, that is all common sense, but this information has to be as the quality score has to be as high as possible. The ideal score that is recommended is more than 7, but I would say as near 10 as possible. Usually 9 by 10 is a very good score, and that is what you should aim for, unless there are certain drawbacks. And having said that, if you have an imaging problem, then imaging is not a good modality at all. As in, if you have imaging artifacts or if you have imaging issues because of media opacities, then it's better to avoid imaging if it is giving you artifacts. Besides that, the most important scans are this number 3, because if these are not good, then all your other analysis goes for a toss. So always see the tomogram images, see the segmentation lines, whether these segmentations are done properly or not. Always use monochrome in this. Do not use colored images, because that will throw your judgment off track, because it will be too noisy. And then obviously you have to see these thickness maps. If there are artifacts, if you have black patches here, missing data here, then they are not good. And this in this RNFL deviation map, if you have this unfast image which is distorted, or if there are misalignments in this these scan images, then you know that the quality of the scans are not good. So not only the QC is not only done from the quality score, but also from these 3 images. And once these due diligence is done, then the central images, you can put the data into perspective and then clinically correlate, so that to make a decision about whether the scan is normal or pathological. So it is very important that you go in a systematic fashion, but obviously without seeing these qualities, then do not even look at the central tables. That is the bottom line that you can take from this slide. Always it is important that having seen this map is not enough. The next thing that you have to see once you see this map is this map, that is the ganglion cell analysis. Often there is a mistake in where you see this map as a only printout along with the patient, and you try to make a clinical decision, and there you can go completely off track, because ganglion cell map can give you a lot of clue as to the non-glaucomatous optic neuropathies, and as we'll see with examples in the next few slides. And that's why these 2 maps have to be seen together. So that is the very important take-home message. Now we go directly to the examples why OCT is important in clinical practice, and I'll cite with a few examples in the next few slides. So this was a 50-year-old male on anti-glaucoma treatment and posted for glaucoma surgery in view of progression. Now you can see his visual field tests which are done elsewhere, and these are showing the thing that should strike in your face is the test-retest variability is very high, and you can see that the defects are changing a lot. Now, had you not had the OCT with you, then this kind of disc with the inferotemporal thinning and a large cup disc ratio with a cup disc asymmetry would definitely push you towards, thinking that clinically things are not too good. But if once you see this, you know that the patient is not a good performer of test. You can see also here this kind of variability. So natural thing for us was to just do a reverse trial and do his imaging. And when we did the imaging was completely normal, and over a period of time the imaging did not change. Although you can see when the perimetry test was done at our place also, there was the test retest variability was continuing. So irrespective of who's counseling the patient and who's talking to him, some patients are just not meant for perimetry. Here is the role for OCT to help us by saying that there is no progression. So we can definitely put the patient off treatment if so desired. And here it tells you that the patient has been stable without treatment for so many years. So this is a very, very important aspect where OCT helps you in decision making, where patients do not do well in perimetry test. Now this is another example. Like here you can see that the cup to disc ratio of this particular patient, you can make out hardly anything. It's just around 0.1 to 0.2. But the patient was a 58-year-old female, and at presentation she had IOP which was in the mid 20s, and she had occludable angle on gonioscopy. On perimetry, you could see this kind of an inferior accurate defect. Now the point is the defect was reproducible and it was fitting all the Anderson's criteria. Now the point was that if you see this particular disc, you think that everything is completely okay. I do not see a wedge defect or anything. But then why this perimetric defect is there? Now, had in the lieu of OCT, we wouldn't have been able to decipher what is happening. But when you see the OCT, you can definitely see that a corresponding superior temporal thinning of the nerve fiber layer is definitely there, and asymmetry of the area of the disc is also there. Although it is in the green, it is definitely asymmetric in two eyes. So these are the small things that you need to pick. And the ganglion cell also shows the indentation of the donut superiorly. So this classical defect is definitely helping us correlate to that of the perimetry. And this patient definitely underwent a YAG-PI, is on monotherapy, and she's in stable since 4 years. But definitely here you can define that change on the disc basis OCT, but not on the fundus photo. Coming to the next important example, here you have a 14-year-old female patient, and she came for a glaucoma opinion. She was on a brimonidine timolol combination for 2 years. Her pressures at presentation were 16. If you see her disc, optic disc was slightly pale and cup to disc ratio was around 0.8. I hope you can appreciate, but her perimetry test was completely normal. Her pachymetry was within normal limits, and if you see her OCTs, then you classically can make out that the OCTs are definitely outside normal range. Now, here it's very important for us to understand to see OCTs in the right way, because if you see this OCT, you will definitely think this is glaucoma, but the catch here is where the ganglion cell complex tells us a different story. Now, if you see the in the OCT, the temporal half of the nerve entirely is showing abnormality rather than only the superior temporal or the inferior temporal quadrants, and also the ganglion cell is showing a large amount of asymmetry, with the ganglion cell being very thin in the left eye vis-a-vis the right eye. Now, the patient has not changed in the last 3 to 4 years of scanning. And this is a particular case which is basically a hereditary optic neuropathy, which was presenting like with a slightly pale disc and which was stable over time. Now, so this kind of non-glaucomatous optic neuropathies can easily be picked up by the ganglion cell information and the progression printouts on repeated testing. So this does have the robust progression hardware does help us and also mitigate the need for unnecessary treatment. So here you can see that the patient has been stable all through and there has been no change in any of the parameters in the last 4 years. Now, coming to one more example where OCT helps us. Now, this is a perimetry test of a person who was an IB officer, and he came to us with presentation pressures of 32 and 35 in 2013 with normal corneal thickness and open angles. Is the disc size at the CD ratio at presentation was around 0.5 or 0.55, and this was his baseline OCT scan in March 2013, if you can see. Now, considering this, on treatment, his pressures used to come down to around the mid-10s, but as he was an IB officer, he was very, very irregular about his treatment, and he used to default, and then he comes after 2 years. So when he came to us, he was an ocular hypertension case. So we maintained the patient on monotherapy, but the patient used to often not be able to put his drops. Now, after he came in 2016, you can see that the visual fields, whatever he could do in the irregular nature of his profession, was almost stable, and hardly any change in the visual fields. But if you see the OCT, what has happened is his thickness, average thickness of RNFL reduced from 94 to 76, which is defined 100% as progression on RNFL or progression in the green in terms of the machine that we have been using, because we know specific test-retest variability. And the rule of thumb is the more than 2 standard deviations of test-retest variability is defined as progression on OCT in most modern machines. So this was a case of progression in the green. Here you can definitely see that perimetry is not showing any change, but a gross change in the nerve fiber layer. So this is one of the most important uses. If you have a good OCT machine, you can pick up these changes early and definitely counsel the patient more towards treatment. So now this is the fifth and one of the, I think the last, one of the few cases, last cases because of want of time. Now this patient came to us again. I think he was on glaucoma treatment for 25 years. Now you can, this is an old disc image, so you can see that he's got a cup to disc ratio of around 0.7 to 0.8 with a vertical cup elongation in the right eye and a slightly horizontal elongation in the left eye. At presentation on reverse trial, his pressures were 29 and 28 with a normal corneal thickness, and he was stable for 3 years on perimetry. So you can see here that the patient's perimetry is showing you almost normal with some kind of temporal field, few spots in the temporal field here, and a nasal field in the right eye. Now, when these are the tests, if you can see, are 2015, 2016, 2022. Also, the same picture persists, hardly any damage in this particular case. But if you see his OCTs, then it shows a gross abnormality here. You have a gross thinning at at different places in the two eyes. So now when you define this case and you look a bit further, now these were the scans that were available at the time of 15, 16, when ganglion cell map was not that much in vogue. It started coming into vogue later, and see how it helps us. This is what the ganglion cell map looked like. Now, this is definitely a hemianopic split of the ganglion cell layer. Now, this is definitely not a glaucomatous defect. So, as it turned out to be, his neurological history did give the indication of neuromyelitis, and he had an axonopathy. So, bilaterally, he had a homonymous kind of a defect on the ganglion cell layer. So, this was a typical case where the patient had an ocular hypertension with a coexisting non-glaucomatous optic neuropathy. So these are the most important things that you can pick up very easily using OCT, which otherwise you would not have been able to pick up only basis perimetry. Now, one more common question that was asked was myopia, and how do you use OCT in myopic discs? Now, myopia has various phenotypes. The discs look grossly different. You can have torsions, you can have peripapillary atrophies, you can have RP atrophies, peripapillary staphylomas. So all these cases, the methodology has to be individualized. Is no size fits all. You can have the ultimate challenge of pathological myopia. In these cases, you know, the O of OCT also should not come into picture, because you cannot image these kind of eyes. So these cases do well only basis perimetry, and perimetry well done can help a lot in these kind of cases. So when not to consider the use of OCT is these kind of eyes where you have a peripapillary atrophy or a staphyloma extending well beyond your optic disc margin, or when the disc size, you have a megalopapilla which is extremely big. Megalopapilla of that size is very rare not to come under the domain of OCT, but peripapillary atrophy and peripapillary staphylomas definitely exclude OCT as a modality of diagnosis, but these cases do extremely well in perimetry, and you can follow them up with a lot of confidence. Whereas imaging in myopia is definitely not a no-go zone. Now here you can see a myop which is around 4 to 5 diopters. You have a disc tilt torsion with a very unusual peripapillary atrophy. But here you can see that you can have a good centration of the BMO as well as a good scanning circle that can get good scans with proper segmentation. You can see the segmented images extremely well along with your PVD changes also. So basis that you can use these particular OCT in these particular eyes very confidently and follow up myopia in these eyes where the scanning is possible and you get technically very good images. So it's individualized when to use these in myopic eyes, but definitely you have to not abuse the machine in case the scans are not obtained and the segmentation is not proper. So the take home message is you have to know your machine. OCT is a very objective and super fast technology, non-negotiable chain of evidence in establishing diagnosis of structure and function, as you have already established with so many examples. You have hardly any test-retest variability in good hands, thus greater reliability, and it is the sole evidence of diagnosis and change in pre-perimetric states. Excellent tool to detect progression in early to moderate disease, and it can distinguish non-glaucomatous causes of optic neuropathy in the way which could not be diagnosed earlier. So not all OCTs have the same capabilities, and the checklist for use in progression assessment is very exhaustive. So thank you for your kind listening. I would be open to questions and discussion after this. Thank you.
Can you, yeah. So now let's go to the questions. That was a very in-depth lecture, but questions are always something which stimulates discussion, and discussion is what gives rise to learning. So the first question is macular ganglion cell analysis and importance. So Dr. Sushmita, I'll get direct the question to you. That do you always do, like Dr. Sachin has said that he always does ganglion cell and the RNFL together. So what about you?
I do them all together because I don't think it's true that the macular ganglion cell would precede the RNFL. That's how it was touted when the machine came. It's important to understand that it's a topography of the defect, which will allow you to pick up the defects on the macular or the RNFL. So, instance, if there is damage at the poles, which is what we usually see in POAG, superior and inferior pole, then you would have a completely normal GCC, but you would have RNFL defects there. Whereas in conditions like NTG, which have deep central defects, you might actually in the early stages have completely normal RNFL, but early ganglion cell loss. It does not mean that the ganglion cell preceded it. It only means that the damage is at the papillomacular bundle. So yes, I would do it every single time.
All right. What about you, Dr. Ashish? You're muted. You can just unmute yourself.
Yeah, all OCTs for glaucoma will do both RNFL as well as the GCIPL. Cirrus is the machine that we are using, and we use Humphrey. And in the same way, although we are talking about OCT, I would like to say that in most cases, with 24-2, nowadays we are doing 10-2 also. When our suspicion is more towards diagnosing glaucoma in a particular case, doing a 10-2 also helps, as we are giving importance to GCC here. For fields, we should keep 10-2 in mind also.
So for OCT, you would do RNFL and
Yes.
ganglion cell both.
Yes.
All right. And which is the machine that you are using? Zeiss?
We are using Cirrus. Yes, Zeiss. Cirrus.
Zeiss. All right. So to all our delegates that do the ganglion cell and RNFL together, not necessarily because one precedes the other, because looking at where the damage is, sometimes it's like a security camera. You put it at the exit and you put it into the when the people are entering. So entry point, exit point. Sometimes you catch the thief at the exit point, sometimes into the entry point. So now the next question, Dr. Mohit, you want to ask that question, please?
Yeah, and besides, I think the important point is that we can pick up non-glaucomatous optic neuropathies very easily if you have a ganglion cell, which you cannot do if you have only because sometimes you just cannot differentiate, like the example I showed you.
True.
Secondly, the pattern of ganglion cell loss in a normal tension glaucoma, as Dr. Sushmita has said, the orientation would be slightly different. And in angle closure, if you have an episode of sudden spike of intraocular pressure, then the ganglion cell loss pattern is completely different vis-a-vis open angle glaucoma.
True. Important points, those. Yes.
Yes, I was about to ask about the angle closure only.
Yeah.
Like the OCT changes that you see in the POAG and the acute angle closures.
Yeah. So here in acute angle closure, what happens is all ischemic optic neuropathies and angle closures, they resemble the same, provided your pressures are spiked. Now you have to understand these two different things: an acute angle closure with an episode of acute angle closure, and angle closure disease without an episode of acute angle closure are different. If you have a creeping angle closure, it gives you field defects. The OCT defect similar to a open angle glaucoma. But if you have a spike of intraocular pressure, say a 30s or a 40s or a 50s, which has been significant, then it causes damage in a different way. You have a significant ganglion cell loss before the RNFL loss comes to 4. I have a few examples, but I mean, because of want of time, I couldn't include everything. But the ganglion cell just blanks out. You will see a complete red donut there in a Zeiss if you have acute elevation of intraocular pressure, and also for cases like ischemic optic neuropathy. So this is very, very well established also, and we have a lot of examples to cite that also. So that pattern is very, very differentiating of the two. But I'm talking about acute intraocular pressure elevation. Mind this statement very clearly. If it's a chronic elevation, if it's a peeping angle closure, exactly the same defects like an open angle.
So the second question was reading OCT as a pure beginner in glaucoma. So Dr. Sushmita, just quick 4 or 5 points. Pure beginner. So maybe a PG or someone like that who has the OCT printout in their hands. How can they start?
First thing is the RNFL thickness map right at the beginning.
Okay.
Right? So the deviation would depend on what the normative database is. And let's not get into the complexities of age and thickness and disc size and all that. So the next that you have, the first two is the thickness map and the second two is the deviation map. But look at thickness. If it is not red or yellow in the arcuate areas from the disc, then something is wrong. It should not be blue.
Right.
Where glaucoma is concerned. That's the first thing that I would tell a beginner to look at. And do not look at red, blue, green, yellow on the quadrantic map. That's the other thing not to do. Look at the thickness, look at the disc, see if they are correlating. Because again, these are all compared to normative databases and your patient may not be part of that normative database.
So what Dr. Sushmita is trying to say is look at the raw data.
Yes.
And in that raw data, red is good. Otherwise, we are primed to think red is bad. But here is one place where red is good and blue is bad. So that's a very important thing which she said, that look at the raw data and look at the statistical data later. Sometimes you get those red, green, and you get lost in that sea. So now this is a question.
And I think one caveat, Preeti, would be green is not normal and red is not glaucoma.
True. So yeah, there is a question that what is the red and green disease? So I was going to ask that question later on. So how to get the best of Hoovert's OCT for glaucoma? Now, this is a very specific question if anyone wants to take. And may I add that none of us have any financial interest in any of the machines mentioned. I think I'll be safe in saying that, right? Dr. Sachin?
Absolutely.
Yeah, and Dr. Sushmita also, Dr. Ashish also, and Dr. Gayatri.
Yeah, I too would have absolutely. Sarkari Naukar have no financial thing at all. No, but coming back to, if you really ask me, the only reason I would still say go for the Cirrus and the Humphreys is because you get everything on the same forum platform. I think for me, that is so important. If you're really, really going to do glaucoma, having an OCT and a field and a GCA and field and being able to do a structure function correlation on one map, it will give you at one go whether or not the field defects are corresponding to thinning on the OCT. So the structure function map is the best possible thing that Zeiss could have given us. And that's the only reason why I would say if you're doing glaucoma and if you have a Humphreys field, then you might as well go for a Cirrus Zeiss OCT, just for the convenience. But per se for the OCT, I think anything is good enough.
Yeah. So Dr. Ashish, see, everybody does not have the financial capacity to buy. A comprehensive ophthalmologist has to have multiple machines. So if a person is buying Hoovert's, what would you say to that person? Dr. Ashish, any tips for that person?
I have actually no experience using Hoovert's. One of patients referred from elsewhere. We get to see the printouts. I am also not sure about the technical details about the machine, so I would not be the right person to comment about it.
So to the person who asked this, most of us have not used the Hoovert's OCT. And as Dr. Ashish said, it is like patients who come to us, floating around with multiple machines and multiple printouts. And that's what we have seen. So Sachin, any tips on that, Hoovert's, or you would say that's the same what all of us have? You're muted.
Knowing the technical nuances, I wouldn't be using any other machine except Spectralis and Cirrus
Fair. Yeah. So that question, the
for
answer
glaucoma.
for glaucoma, yes, fine. So I would say even for Huvitz, if you are buying that machine because of say financial constraints, then I would say use it the same way, that look at the raw data first and look at the, because it also gives you a disk cube. Even Huvitz gives you a disk cube. Look at the raw data and then look at the statistical data. But take it with a pinch of salt that sometimes you may not get the same kind of accuracy or retest variability which you would get for other machines. I think that's what would be safer. Dr.
Yeah,
Modi,
so
you want to
basically,
take?
in short, the caveat is use it as a screening test, not as a progression tool.
True, fair enough. As a
So
one-time.
there the field test will be more important for us than OCT alone.
Dr. Mohit, I've shared the questions if you want to take the next question. Okay, let me take it.
I just
Sure.
yeah, I
Well,
just want to ask, like, rather than that 2 standard deviation change, if we say, let's say, in between the two tests, how much change do you think, like for Zeiss one, how much change in the microns is 14 micron, 16 micron? How much change in the microns do you think that is significant enough?
great question. Yeah. So that is one of the questions. So how much would you say is progression? How would you say noise? So Dr. Sushmita, Dr. Sachin, Dr. Ashish.
First and foremost, I would look at signal strength because that is the most variable thing. And the second thing is sometimes even with a good signal strength, even mild increases in a cataract would give you fallacious things, especially if it's posterior subcapsular or something. Then, it might go through and the machine might say it is a signal strength of whatever. So then that would go. So I would be very, very cautious in assessing progression on OCT. And the other thing to keep in mind, especially for using the progression analysis, which might become a limitation for us, it is because if you have a high volume practice, the progression analysis on the OCT requires all examinations to be in the machine. And usually, if you're using the forum, the OCT pictures go straight on the server and then it goes to the forum to you. So the limitation is that the machine isn't very robust to take too many examinations and the analysis doesn't happen. So it's a little bit of a hassle to go to the server, tell your IT guy, pull back these examinations, then do a progression analysis. And it's okay if it's not a very high volume practice and you can get that. But over a period of time, that's one thing that you must keep in mind. As regard the absolute change, like I said before, even a drop of tear substitute can make the change disappear. A little bit of a cataract, and then you do the cataract surgery will make the change disappear. So in absolute terms of microns, I would be a little, that is why the progression analysis would be far more important because it would take care of all of this. But if you ask me, measuring 8 microns change is a little tricky where OCT is concerned. So have everything else in mind, your fields, your pressures, whether or not, your gut feeling. The patient itself will tell you, मजा नहीं आ रहा, अरे 6/6 revision. नहीं, वो ठीक है, but that subtle contrast, the subtle change. I used to be able to go out at night for a late evening walk. I'm scared now. So बहुत clues come in. So I don't rely on OCT as a progression tool, really.
Dr. Ashish.
Yeah, I totally agree. It is not just that number thing that we are looking at. Theory in books will read that 5 micron change in average thickness, or 8 or 10 microns thickness in a quadrant change, or 12 microns change in a clock hour thickness. That is all right as just a guideline, but you have to actually look at what is actually happening to the patient. Starting right from your slit lamp examination to starting right towards giving attention to how well that image has been procured. Just that drop that she mentioned, making sure that the ocular surface is good. Similarly, you can have other media opacities causing changes in the RNFL thickness. So going absolute by the numbers only won't be a good advice.
So if I'm safe in giving a message to the audience, that don't go into absolute numbers.
Yeah.
Repeat. Like perimetry, there is noise even in OCT, maybe to a lesser extent, but it looks very fancy. So don't go by numbers. Look at the overall thing. If there is a change and the intraocular pressure is uncontrolled, the patient is non-adherent, yes, you would believe that change. But if you find that no, everything else is all right, you may not believe it. So repeat. I would say it has to be repeatable and use the statistics for detecting progression. I would say those.
One
one
small pattern recognition that you can do is on the GCA. This is where it is very useful.
Ganglion
So
cell.
you see the pattern on the GCA, and okay, this much was yellow. आज ये yellow थोड़ा कम है. It's a little more blue. See, this area was yellow. This is blue now. Why is that happening? So that clue will come in. But I really don't look at numbers. I look at more
And
pattern.
by the very nature of the disease, most patients you would be happy or satisfied looking at the overall trend, looking at the trend over time rather than looking just at that change at a particular time.
So there is one question.
The change, however, has been defined in multiple studies since 2014. Chris Leung and group have been describing age-related loss in microns to the tune of 0.5 microns per year or something like that, which I feel is too far-fetched. But in all modern machines, if you follow proper protocols, 5 micron to 6 micron change for a spectralis, around 10 micron change for a Zeiss is usually accepted as progression. Now, I am telling this with and after taking all precautions of not going overboard, because we've been having these results over the past more than 1.5 decades with the imaging, and we are pretty confident. See, the problem lies in not understanding and not being accurate with your measurements. So what happens is, if the image acquisition protocols are not very strict, or if you do not have a device that can track, or you can get reproducibility to the T, because if you see the test reproducibility is around 0.96, 0.97 in some machines, which is absolutely, world class. So if you get that's why I said when I said that I wouldn't use any other machines was with a good reason, a good scientific and reason of physics, that these changes, when they are detected by these machines, obviously, as Dr. Sushmita said, you have to be careful about media opacities, developing cataracts, all those things. But if you tick all the boxes, you can definitely detect changes north of 5 microns. I wouldn't say less than 5 microns anytime. 2.5 microns is the lateral and axial resolution of a spectralis. So as I said, twice more than your normal standard deviations would be what I would take. But I'm not saying that everybody should use this. As they have said, you can use your clinical judgment, because if you want to use these parameters, you have to be extremely good with what you're doing in terms of imaging.
Yeah, because
That
if
may not be
people
everybody's.
start using this, to 5 microns change as progression, most of them will start operating patients. So we don't want that.
So that's what I'm saying.
So,
You can use it provided you're responsible enough in using the machines and you know what you're doing.
so for a comprehensive
So at least
ophthalmologist, we would say,
if not 5 but 10 microns is just over this thing.
so we would say repeat it, correlate clinically. If it continues the same pattern, then yes, you can say that this is progression. So now that this is a very different question. If there are a few spots seen on perimetry with correlate with OCT, so we are talking about maybe early damage or no damage, no high pressure, can we still go ahead with trifocals? And so it's not related to OCT really, but cupping is 0.6, 0.7. So what I think the person is trying to say is that there is early glaucoma or maybe doubtful glaucoma. Can we use trifocals? That's what the question is. I'm trying to interpret that.
White hair makes you conservative. Today it is early glaucoma. That trifocal is going to stay for the rest of his life.
Yeah.
5 years down the line, he may not be early glaucoma again. And if he is going to have contrast problems, you've put in a trifocal lens, my answer would be no.
Okay. So am I safe in saying that yes, if you have diagnosed glaucoma, then trifocals is a no, because you don't know how it's going to progress. But if it's a suspect, say ocular hypertensive, stable with follow-up, you can probably go in with trifocals. Is that what I can tell the audience?
Absolutely.
I'm not sure what the OCT would be like with the trifocal.
Yeah, so what happens is you do get artifacts
Yeah.
in a trifocal in OCT. So what, as Dr. Sushmita has correctly said, I would just put it in physical terms, in the terms of physics. You do not put any aberration inducing optics in a eye which is already having contrast compromise. Very simple.
Yeah.
Do not induce aberrations, because those aberrations will affect even your examination of the disc. As simple as that. It will affect your fundus photographs, which will not be able to focus, and it will also affect your imaging.
Yeah.
So please do not introduce these kind of irregularities in a compromised eye.
So that's the answer. If it's definite glaucoma, definitely no trifocals. All right. So that's one thing. And okay. OCT, RNFL in high myopes, which you have explained very properly. But just one line again from Dr. Ashish and Dr. Shushmita, that how do you use OCT in myopes? Just, he's already given a very nice explanation, but something, because it has, that question has been asked 5 times at least in the question answer. So that's why I'm saying,
Yeah.
well, let's give some weightage to that question.
Yeah, and a very valid question also, because anyway, myopia as a risk factor, we think in terms of glaucoma suspect, right? So many myopes you will want to assess for as a glaucoma suspect. So we do both the things together. We'll do the fields, we'll do the basic glaucoma workup, we'll do the OCT, both RNFL as well as the GC-IPL, keeping in mind that the image acquisition could be little difficult as compared to what you would get with other regular discs, and having a good baseline is what I would be more concerned with. Having a good baseline data with a good image quality, good proper segmentation, and then following up the patient duration depending on what are the other risk factor for that patient for developing glaucoma. If you already have a field defect, your clinical judgment is tilting you towards diagnosing glaucoma, then your pressures also are telling that yes, it is something that it goes in favor of glaucoma, then starting treatment or not starting treatment would be absolutely a clinical decision. But what I would emphasize is having a good baseline image and then following it up, especially for a suspect with myopic discs.
Your 2 points on it, Dr. Sushmita?
Yeah, most myopes would also have reasonable peripapillary atrophy, and that would affect your segmentation a lot. So for me, I would do the follow-up on fields and take a field as a baseline and assume that the chorioretinal degeneration and everything in a high myope is due to that, and any increase, because otherwise the degenerations of myopia are usually stable. And if there is an increase in that, I would rely more on fields than an OCT in a high myope.
So high myope, so it's a lot is said about ganglion cell complex, using ganglion cell complex for myopia instead of the RNFL because of the presence of the atrophy. When do you use it? In moderate myopes, maybe? Do you use it for moderate myopes or low myopes?
Yeah, I
You
mean,
can use it if you get a good image.
yes, if you get a good image, correct. I mean, then, with the high myopes, see, it's plus minus 5 diopter spherical and plus minus 3 diopter cylinder is what the cirrus corrects for. So you have to train your optometrist to put in those extra lenses, which they come, and then you have to take an image. So it's a little more tricky since we are all not doing it ourselves and depending on other people. So for me, getting a fields in is so much easier and more reliable. And
in these patients, take combination of everything. In a very high myope where the retina is distorted, there is peripapillary atrophy, you're not likely to get a good GCC also. I would say perimetry remains the pillar in which you're going to decide the damage and the further progression.
Yeah.
Okay.
The other one thing about my residents asked me is a GCA and a GCC. I just want to make it clear that they're two different things. And on different machines, the GCC on the cirrus does not include RNFL, and the GCA includes the RNFL. So be very careful of what you're imaging. I mean, don't go across machines to compare. They're different things.
That's a great tip. Yes. Yeah. Now this is, is OCT RNFL thickness reliable for assessing progression? Because many patients are not able to do field reliably. So in the absence of a reliable field, can you use OCT? Dr. Sachin, yes or no?
Absolutely, yes.
Yes.
Provided you get the right kind of images and you have the right kind of machines.
Okay.
I just showed the example of the
Yes,
RNFL
exactly.
progression.
Yes, you have addressed that question very well. And so I would say we'll go into the next question. Okay, which
Just one point to
Yeah.
remember when you're
Yeah.
using progression on the OCT, remember till date it is assuming zero slope, which means the comparison of progression is assuming there is no change of GCC or ganglion cell over age. It does not take into account age-related loss. It is only measuring against normal and no change, whereas a progression on the visual field, GPA takes into account a glaucoma person with the same age and the same damage. So you're comparing your patient to a stable glaucoma patient of the same severity on the visual field, but on the OCT, you're comparing it to a normal person with no age-related change also. Glaucoma to dur ki baat hai. So that when you're using stats, please keep that in mind.
So that's a very beautiful point brought out, that age also changes. Age also thins the OCT, but that change is not taken into consideration when you are assessing progression.
When you're doing it with the statistical analysis of the OCT software
OCT.
as compared to a visual fields software.
Now this is something, which OCT machine is most accurate? So you have already said that, but we want the names. So Dr. Sachin, which according to you, Dr. Ashish and Dr. Sushmita?
No financial interest. Technically,
Absolutely.
the most superior is Spectralis.
Hmm.
Second comes closest to Cirrus 6000.
All right. And you would not use any other machine?
No.
No. All right, Dr. Sushmita. I know you are saying Sarkari, so whatever Sarkar is giving
No,
you.
I know. I mean, we have both the Spectralis. It's just that our clinic has, and I told
They
you
have
that,
everything.
Exactly, that's what I'm saying.
that the Humphrey.
Don't go by the word Sarkari. They have everything.
No, I said the Sarkar has given everything. That's what
Yeah, the Sarkar has given everything, but since we have the Humphreys, we like the Cirrus. I'm not so sure about accuracy because I don't know how close they are to the histology of the ganglion cell thickness. So I'm not sure of accuracy, but in terms of clinical use, I think both are. I mean, if I had the Spectralis in my clinic, I would have used that. I have the Cirrus in my clinic, so I use it.
Dr. Ashish, see, we are poor private practitioners.
Yeah, no,
and
even and if we are talking about companies here, you take a Cirrus or you take a Spectralis, somebody has a Topcon or somebody has a OptoView,
Correct.
and a good quality or
Yes.
a good brand SD OCT machine should suffice
Should
if
suffice, correct.
cost is a consideration.
Yeah, thank you so much for that, because as I said, a comprehensive ophthalmologist cannot sometimes, there are cost financial reasons, and even these are recurrent costs. So yes, you can use a good machine provided you know how it works. That is, Dr. Sachin has said, know your machine well, know where it fails, where it helps. Each machine will have its strengths and its drawbacks. Know those machines, talk to the people and those who use it, and also the company people. They will only tell you the positive points, but the competitor is going to tell the negative points. So when you're looking for machines, you talk to different people and try to find out the plus and minuses of the machines. So yeah, now there is one on, can we treat a patient only on findings of NCT, or is applanation a must? This is not related to OCT, but this is glaucoma week. We should be giving you the correct information. So Dr. Gayatri, is she there? Because I'm not able to see her. Dr. Gayatri?
Yes, ma'am.
This question for you. So, can we treat a patient only on findings of NCT?
As far as I think, NCT should be just taken for screening. To diagnose and treat, applanation is a must.
Yeah.
Because that is only the gold standard. And NCT will definitely give you some variations in the intraocular pressures, maybe high or low, and maybe people will be over treating glaucoma based on NCT.
True. So I think we all agree, and we send a message for glaucoma week. One strong message.
Absolutely.
Only, okay, rebound or NCT is used only for screening, and for treatment, please use GAT. Confirm with GAT. And glaucoma, anything with the word G and ocular hypertension should be only monitored with applanation. Okay. Red disease, yellow, red, green, and yellow disease. That's what the question is. So if any of you can elaborate, Dr. Ashish, if you can elaborate.
It's basically to differentiate between what is normal, what is abnormal. If you look only at that OCT printout, like we talk for fields, if you look at only the OCT printout, you will always be making the mistake of diagnosing a red or a green disease. If you, on the other hand, give importance to your clinical judgment, what actually you are looking at, the dilated disc evaluation with your stereoscopic lens, and then correlate it with a good quality image that you are seeing on the OCT, this red and green disease is not going to bother you. But yes, you should know that there would be instances wherein everything, the patient finding wise, everything is normal clinically. Patient has glaucoma perimetrically because the patient was not able to do the fields. You can have situations wherein you will have all red on that OCT printout, and your clinical assessment of disc says that this is absolutely a healthy disc. So do not forget to correlate things clinically, then these things will not bother you in your clinical practice.
So, Dr. Sushmita, if you can just say, what is red disease? If you can just define it, and how do you recognize it? Red disease.
So the OCT, especially the Cirrus, has a 350 odd Caucasian adult eyes as a normative database. So when something is flagged in red, it only means that the thickness of that particular patient is seen in less than 1% of those normative people, but they are normal. You see that even though it is in red, it only means that it is seen in less than 1% of that normative database. So the likelihood of being normal is less than 1%. Whereas if it is between 1 and 5%, it's flagged yellow, which means the likelihood of it being normal is less than 5%. And if it is between 5 and 95%, it's flagged green. And if it is more than 95%, it's flagged white. But all of these are normal thicknesses of somebody. So there are some normal people walking around who have a thickness which falls in less than 1% on your OCT machine. And therefore, red is not automatically glaucoma and green is not automatically normal, because somebody with a very thick RNFL might have glaucoma and the OCT flags it green simply because that thickness is within the 5 to 95% of normals in that particular machine. That's what it means. It's only a statistic. It's nothing else.
So what?
That was that example which we showed you, no, in the where
in your lecture. True.
Yeah.
You showed those red and
green disease was there.
So what I'm trying to say is green is when a child, because we like to torture our children with marks, if a child is falling from 95 to 90, it will not be flagged. So that's what I'm trying to say. If a RNFL has fallen from 90th percentile to 85th percentile, it will still not be flagged because it's not gone into the red or yellow zone. So what we mean is that green diseases, presence of disease when statistics shows normal, and red diseases when statistics showing that, oh my God, you are in trouble, when actually you're not. So that's what we mean by red and green disease. And the next question I'll direct to Dr. Mohit. How frequently should OCT be repeated in diagnosed cases? Dr. Mohit, are you there?
Yeah. Yes.
How frequently?
So in the in the first 2 years, I would like to repeat the OCT or HVF at least 6 monthly. And once I find out ki, okay, the disease is stable, or I find out, okay, the baseline things are these, then I can repeat every 1 year.
Okay, fair enough. So, Dr. Sachin, every 6 months?
The protocol that I follow is initially the perimetry baseline. The initial 2 years would have at least 5 tests of perimetry.
Initial 2 years.
Yes.
Perimetry.
And and then if the patient is stable, progressing, the frequency will change. Advanced disease, it will be every 4 to 5 months.
OCT.
For early disease, maybe once in a year. No, this is for perimetry.
No,
for OCT, usually in advanced disease, I do not use OCT at all.
Correct.
For early and moderate, once a year usually suffices, unless the patient is unreliable or a poor performer, as the one which I showed you. In those cases, I may repeat the OCT 6 monthly if I feel it is a high risk case. Otherwise, once a year OCT is fine.
So early to moderate, 6 months, very high, say,
No, annual OCT is annual, irrespective.
Okay.
But unless the patient is a very poor performer on fields, or I can't rely on fields at all. And if he's a high risk case, then maybe 6 monthly, but otherwise once a year is fine.
Okay. So Dr. Mohit also has given us the thing that 6 months, 1 year if it is very early damage. And in ocular hypertensives also once a year, Dr. Sushmita?
Maybe even further, 18
Further.
months.
Fair enough. Yeah, 18 months, right. And now just, does every patient of glaucoma, does it undergo a screening OCT? Or ocular hypertension? This is the question. Does every patient go through the screening OCT for early detection?
Yes.
I don't know what the person means. Every patient, obviously, we are not going to do OCT. I think every glaucoma suspect is what probably the person
Yes,
means.
yes.
Every
Correct.
glaucoma suspect is more important than a glaucoma patient.
True.
I would be okay doing only visual fields in a glaucoma patient, but it's the suspects where likely the OCT change would come up before the field defect comes. So I will do it more.
No,
100%.
absolutely. Now, I think we are coming to the end of
I just want to put in one point, Preeti, which I've put in for the last 20 years.
Please.
And I'm putting it in again.
And
This 30% business. 30% of OCT will be damaged before the first field occurs.
oh yeah,
30% of the ganglion cells present at the point at which the visual field is being tested, not 30% of the entire 1 million ganglion cells before you get your first nasal scotoma. I mean, that's how the OCT machine was sold to us until you really, really read. And I was really intrigued. Acha, 1/3 khatam, then you have the first field. No, it's the point at which your field is being examined. That locus ka 30% goes before that point is this thing. So it's something to really keep in mind, this 30% business.
So what Dr. Sushmita is saying very clearly that yes, we can only say that RNFL loss occurs before perimetric damage, but you don't have to panic कि 30% gaya, because that sort of reflects into 50% तुम्हारा नजर गया. That is how patients are scared,
Yes.
you know, कि 50% नजर चला गया. That's what. So, and one of the last.
How you talk, like, considering this is glaucoma week, it's very important to mention in this talk that how you speak to the patients is very important.
Absolutely.
You know, not to make them paranoid is the first principle of glaucoma therapy. So even if there is progression in the green, there is no functional loss that is happening. So you don't have to shake the patient. It's a wake-up call for you to maybe think about your treatment, but nothing to shake the patient out of his boots. So that's
Yeah, yeah, great. And did we speak about family screening? I mean, in case of very strong family history. So, because it is the Glaucoma Awareness Month, and just to complete the
glaucoma suspects we did speak about, but not particularly screening, but all patients who have relatives, they are glaucoma suspects in that sense. So would you screen, or that's another?
So would you screen, and what screening, what all would you do? Like a son of a patient who has had moderate glaucoma, for example, what would be the test that would you advise apart from just the clinical examination of the optic disc and eye pressure?
Genetics or risk stratification. That's something which
send patients to PGI Chandigarh for
that. That's something that's going to be part and parcel of medicine.
Yeah,
very,
it will
very
come
soon.
soon, yes.
So the risk stratification is so important, and NGS is cheap, 10,000 rupees for a whole exam nowadays. So it's cheap, it's easily affordable. And even for somebody who's not very rich, which is what all my patients are, all I have to say is, how much do you spend on a mobile in a year? And that's it. That sells it. That this is something which you have to do for the risk stratification is so important. The young patients are so concerned with their children. And prior to this, we used to call them in every year, at least do an annual checkup, whatever. This makes it so easy. You do an NGS of him, you screen the variant in the child. If it's there, My goodness, this boy comes in to me every single year until the rest of his life. I'm going to check his pressures and please. It's not there. His risk is as much as 2% of the normal population. Don't worry.
From which age onwards, ma'am? From which age onwards?
No.
What age onwards?
The risk stratification is in your genes. So
Yeah,
if,
so from
if
how
a
old?
glaucoma
Yeah.
patient comes and we get the genetics done, and then we just screen that variant in their children, that's over. That
Right,
child
which
might,
age of child? I mean, at 5 years, 10 years, 20
that
years?
child may be 1 month old, that child may be
Okay.
20 years old, that child may be 30 years old. It's a stratification of risk. If you have the
Correct.
variant, your risk is so much more. If you don't have the variant, forget about it. So not having it is very, very good. It's a huge sigh of relief for a lot of families with glaucoma, especially if you have a family history. Now you have, I'm just saying, you have something more in hand. So at least offer
Are
it.
all the panelists also using it? All the
No.
other panelists also
No.
using it?
So far, no.
No, you can offer it. You can say
Yes,
that
they
now
can.
it's possible. You can talk to somebody who's doing it and it's possible, and we can stratify risk. It takes a huge burden off their heads.
True.
And those who are
No,
not getting that done, what test would you do? Yeah, suppose.
No, in absence of any signs that indicate glaucoma, just a routine eye checkup. Nothing, no testing at all.
So what we do for an established glaucoma patient who is coming to our OPD is during the counseling, we'll talk about the risk factors, no? Or some patients themselves will ask, what is the risk for direct blood relation? The risk we will explain that if it is a sibling, the risk would be high than going it from parents to children. And what we'll advise is to get a baseline eye examination done. We do a regular complete eye examination, and that individual risk for that particular patient, then we decide whether to do investigations like an OCT or Humphrey. That family history is a risk factor that we add on to that patient and then decide whether to go ahead with investigations or not.
Right.
Those are beautiful tips, and we have finished our questions. How to interpret the disc is one question, but that's a completely different webinar by itself. So that we would take in future webinars, but otherwise we have how to detect early diagnosis of POG compared to perimetry. All that has been answered very well in the in his presentation only by Dr. Sachin. So it's now a 1-minute video by again Ajanta Pharma, and then we'll talk about one last question. So we can have that, please. Yes, so glad to be back. So Dr. Sushmita, one last tip for patients on OCT. One tip.
Look at topography of disease before interpreting OCT findings. Look where the damage is.
Where the damage is. Dr. Sachin.
Yeah, basically it's the reverse way. Don't you have to actually expect where the damage is and then look at the OCT.
Yeah.
So you already should have a picture of the clinical judgment in your mind, and then you should clinically correlate. Secondly, always correlation should be always there. Without correlation, there is no using investigations blindly. So that's very important. Secondly, if you are using for things like progression, then you better be proficient at using the machine, because without that, a lot of wrong errors in treatment can occur. So you should exactly know what you're doing if you're using for progression. Otherwise, just as a screening test is fine.
Dr. Ashish. One last tip.
For image acquisition, the routine protocol kind of thing that we follow is the first thing that we'll do is get an OCT before subjecting the patient to eye examination. If your image quality is good, great. I'm talking about a disc suspect who is coming, a glaucoma suspect who is coming to you for an opinion, or if it is a follow-up test also. First, the patient will be subjected to OCT, then the examination part and all. If the OCT is indicated at that particular follow-up, if that image quality is not good, then post dilatation, again making sure that the ocular surface is good and going ahead with the image. So that is something that we give emphasis in clinical practice, so that we get a good quality image, because we have the technician doing it and we are not able to be there, present there during each image acquisition.
Yeah. Dr. Mohit, any tips? And Dr. Gayatri, and then we'll end the session. Dr. Gayatri, yeah,
Yes, ma'am.
any tips?
Yeah, I would just like to tell, like I have seen many people just treating based on OCT, glaucoma based on OCT images. So I would just request them to have a complete eye checkup, correlate it with your disc and findings, and then treat not just based on OCT.
Yeah, that's a great tip. That OCT is not glaucoma, and
Yes.
don't advise surgery based on 5 micron change of this thing. So correlate the messages, correlate, as Dr. Sushmita has said, Dr. Sachin has said, Dr. Ashish and Dr. Gayatri, correlate clinically and then decide whether this patient has glaucoma or no. With this, we end this wonderful webinar. Dr. Sachin, I am very grateful for that great presentation. Dr. Sushmita, Dr. Ashish, Dr. Gayatri, and Dr. Gajbie, thank you very much for your wonderful tips and contribution. Dr. Anaga Herur, who is the president of Maharashtra Ophthalmic Society, thank you for the initiative. And I thank also our viewers, because they really help us frame these webinars, and of course to Ajanta Pharma for a very smooth execution. So thank you all, and to the ladies of the group, have a nice.
Thank you, ma'am. Thank you.
Thank you. Thank you, Preeti, for moderating it so well. And thank you, everyone. Dr. Sushmita, Dr. Sachin, lovely presentation. Dr. Ashish, Dr. Gayatri, Dr. Mohit, lovely. Very nice discussion.
So
I think this can be like, something which we can view again and again. So it's going to be there in our archives. Thank you so much.
see you all at
See
AI.
you all. Yeah.
Bye.
Good night.
Good night.
Yeah.
Bye. Bye. Bye.
Bye.
Good night.
Bye. Thank you.